welcome everyone to the SMA breakout room. I may be a little bit biased, but I'd probably say it's the best breakout room of the day. We've got two great guest stars joining us today, being Dr. Christina Liang and Professor Michelle Farah. So a quick bio we'll go over before they start talking. So Christina is a neurologist with a subspecialty interest in neuromuscular and neurogenetic disorders and Parkinson's disease. Her doctoral studies were in the management of adult patients with mitochondrial disease, and Christina cares for adolescents and adults with inherited and acquired neuromuscular conditions at Royal North Shore Hospital. She's actually my neurologist, and I'm sure a number of other people in the breakout room have Christina, that are adults, have Christina as a neurologist. And she's also a research fellow with the neurodegenerative service at NEURA, or NEURA, I believe. And Professor Michelle Farah, I'm sure she's also a very familiar face for lots of people in this room. So she's a pediatric neurologist at Sydney Children's Hospital, Randwick. She's also a professor in pediatric neurology at University of New South Wales, Sydney, and a specialist child neurologist at Sydney Children's Hospital, leading in neuromuscular clinical and research programs. So her team is focused on developing and translating innovative ways of providing the best possible care from the time of diagnosis through treatment and beyond to people with neuromuscular, neurodevelopmental and rare neurogenetic diseases. And the research program also integrates interdisciplinary genomics research, sorry, I'm struggling here, together with the community and consumer involvement. So apologies for butchering a few of those pronunciations. They're difficult words and I'm not a doctor.
That's ridiculous.
So today is a bit of an interactive session. Feel free to jump in with questions at any time in the chat. But to start off, we're going to start with Christina going through a bit of a presentation and then followed by Michelle. So I'll hand it over to you, Christina.
Thanks so much, Tate. Can I trouble someone to allow me to screen share?
I should be able to do that. Let me check.
Yeah, and at the same time, maybe I'll just check. I've got some slides prepared, but I think you're all very well educated about your SMA. Is anyone relatively new here who wants to kind of hear a little bit of the basics? Because otherwise I might just skim through some of the slides to allow kind of more discussion.
Are you not able to share your slides?
Host disabled participant screen sharing. Well, that's what I'm seeing at the moment.
Yeah.
So we'll wait to see what the outcome might be in 2024.
That's a great question. So I think there's a couple, there's the higher dose nusinersen, and I think a lot of people do say that they feel like it wears off just before they get their next injection. So it'll be interesting if a higher dose has any difference, but we don't know yet. I think that there's also the idea that if nusinersen chemically is modified in the future, that the dosing regimen, like it could last in the body longer. So maybe in the future, if it's slightly different, it could be once a year dosing as well, which could also allow higher dosing. So I don't think the future of SMA therapy is nusinersen every 4 months. From the gene therapy perspective, we are currently giving it as a single intravenous injection, and that is really limited in terms of who can access that because the dose is so high. It's per body, it's per kilogram, so it's not safe. Well, we don't yet know if it's safe at higher doses, and safety is really important. So one of the studies that is happening is giving gene therapy intrathecally as an injection, like how nusinersen is given, and that would be a single intrathecal injection. And it potentially may be as good as intravenous gene therapy or as good as nusinersen. So you can see that the way SMA is treated may change in the future even more. And the myostatin inhibitors are really quite interesting because the 3 approved therapies all target increasing the protein that is really important for SMA. But now we know that they make the nerves healthier and stop the nerves from becoming sicker over time. We think that if we have a situation where you're living with healthy nerves, can we make the muscles healthy or grow to be stronger as well? So the idea is that myostatin inhibitors, so that's a Scholar Rock, and Roche has one called on a clinical trial called manatee, which is a type of fish, that they may actually promote muscle growth so that the nerves and muscles connected together can get stronger. And so we're looking at that space very carefully. And so there's 2 myostatin inhibitors being developed by 2 different companies. Now they have a checkered history because they have been previously used in Duchenne muscular dystrophy and not been shown to be effective. But I think the science behind it really shows why that was, and that the way they were designed, they weren't binding properly with the muscle. So the scientists went back to the lab, learnt from those past science and redesign the drugs, and they think it's going to bind better. So we don't yet know if that's going to be true. But one of them is given as a subcutaneous injection, so it could be done at home potentially with some help. And the other one's an intravenous injection. So I think that's a space to watch, which is completely different to anything we've seen. But it's a kind of like what happens in other areas of medicine where you're taking not just one approach, because, you know, risdiplam, nusinersen and gene therapy, they're all acting on the same place. So taking all 3 doesn't really make sense if you're all going to the same place. But if we're acting on different places, we might actually get more benefit from that. And that's what happens in multiple sclerosis. That's what happens in cancer medicine, where you might take 2 or 3 or 4 drugs, but they're all acting in different places, so that combined they're better.
Thank you.
Let's just see if we can get you onto co-host Christina. She's still in the room, or she popped out? I think Christina's just about to come back with co-host, and she can finally get that presentation up any minute now. Does anyone else have any questions? Maybe while we wait for Christina, we're just having a few technical difficulties here with hosting, as it always is. Feel free to jump off mute or send a chat into the text box, the chat box.
How long do you think it will take for risdiplam to get ready to go for adults? I guess that's a question for Christina, but I just asked Christina to come out and come back in again because that was potentially the solution to her being able to be co-host.
Yeah, I don't know the answer to that. Does anyone know the answer to that?
So we have
I guess
we have approval by the PBS. What are the next steps for that to get into the hands of adults?
Yeah, well, I don't know if you're all aware that there's a Friends of Parliament event which you'd all be welcome to come to on Thursday.
I'm coming to that.
Yay, Ellie, take it. Well, hold up the flag.
And so I believe the health minister is scheduled to talk. So let's ask him on Thursday. That's what I think we should do.
Yeah, that'd be really good. Yep.
That's why I'm going.
Yeah.
So we can and I mean, on that note, it's an opportunity to thank the government for their support of SMA, but also to highlight what we want to do to improve lives and health and living. And so are there any, for those of you that aren't coming, are there any key messages that you would like us to highlight on your behalf? Because I'd be very happy to do that.
Well,
I was going to...
Yeah. I mean,
I was going to highlight the importance of NDIS and ongoing care and support, and the SMA is not solved by just putting 3 drugs on the PBS. That's what I was going to do.
But also that it will, you know, for those of us who haven't elected to have any treatment yet, it would be a first opportunity to get treatment.
Okay.
So that needs to be, you know, done as quickly and as painlessly as possible for everybody. And, you know, now that it's approved, that doesn't really mean anything unless you're actually getting access to the drug. Yeah, and to keep people working in the workplace, you know, to keep people typing and using their functions that they currently have. Like, we don't want people to, you know, progress. We want people to be able to continue the work and the lives that they lead at the moment and not, you know, get any worse. So I think we have Christina, which is exciting.
Yes.
Christina, you're back.
So sorry.
No,
Yes, I
not
managed to
your
get on
fault.
and share the screen.
Technical problems.
But so as you know, I missed a little bit of that discussion, just jumping in and out of the room. But last year in August, one of you were actually on the Sydney Morning Herald. I just didn't put up the picture, just not to embarrass you. And another SMA member on news, ABC News, was talking about risdiplam on a compassionate access program awaiting for the drug to come onto PBS, which I thought might be a lot of adult patients' questions this year about, you know, do they go for risdiplam? So as you can see, this was what I was going to talk about, but I suspect you know a lot about it already. So I'm going to skim through those and probably just skip right ahead later on to consideration that we should think about as an adult. So SMA, you know very well, and the incidence of live births in New South Wales is an autosomal recessive condition. And then we know that there's the SMN2 gene, which is a paralog or a lookalike to the SMN1, which without the exon 7 produces a non-functional protein. And we know a lot of you actually ask about your SMN2 copy numbers because you know about the type that's correlated with the SMN2 copy numbers. Many of you know that as adults, you would have experienced deterioration in the function since when you were much younger. And then this is a study of patients aged between 2 to 30 over a 2-year period. And you can see that the assessment, and here they use the MFM total score, and down below is the change in grip strength. But when you get a little bit older in adults, the change may not be as obvious year to year, which is why in the adult, it might be harder to find a kind of a meaningful assessment to say how people are going whilst they're on treatment. This is another study from the Italian group, just to show that adults can have a range of ability with their revised upper limb module, as in how their upper limb functions. And then this is just put in to say that there is actually a formal study to note what people want. They want treatment that can improve their motor function, their breathing function, that can be taken either orally or as a one-time infusion and with minimal risk. So with that in mind, we have a quick look at what's available, and we know that very well. I'm going to not talk about Zolgensma because that one is for children, but we're going to concentrate on the nusinersen and the risdiplam. So the nusinersen, you know very well, is an antisense oligonucleotide, whereas the risdiplam is a small molecule, but both of them work to modify the pre-mRNA, which is like a template where, if you will, the protein is made out of, so that the SMN2 protein can become functional. You know, for those who are on it in particular with the nusinersen, it's a little bit of a hassle of getting the loading doses of the 4 doses over about 9 weeks and then every 4 months. And then with the risdiplam, it's an oral agent that needs to be refrigerated for a short period. For those who travel, it can be up to room temperature, I think, for about a week or a week and a half. It's a standard dose as long as you're over 20 kilograms. It's 5 milligrams a day, which is equivalent to 6.67 mils daily. And you need to kind of extract that from the bottle. So each adult will be prescribed 3 bottles of this per month or just over a month. And you get 6 months supply if you do want to go over to risdiplam. But you also need to make sure that the syringes actually come with the bottle, because it's a specific syringe you can't get anywhere else. So nusinersen you know well, so I'm not going to go through that detail, except maybe this newer study from 2023 of patients who can walk within that Smart Care Registry study of 231 patients out of 1,190 based in the European registry of 38 centers over just over 3 years. And this is just to echo what we are noting in the adult patients, that when you look at the line of how people progress over the 3 years of the mean 6-minute walk test, the red is the adults and the blue is the pediatrics. So a lot of patients, despite being on nusinersen, might find that their walking distance might be about the same without a huge change over the years. But on the contrary, patients might be reasonably stable. And in this particular study, about 27% of both pediatric and adult walkers managed to improve more than 30 meters on a 6-minute walk test over that period. However, there are also a minority of patients in 8 adults, that's about 7%, who did decline more than 30 meters on a 6-minute walk test over that period. And out of those 231 patients, 3 decided to stop the treatment. The Hammersmith score, which is the more global kind of upper limb, lower limb functional scale, and the revised upper limb score, improved in the pediatric population, but was stable in the adults. And those are the graphs. You can see that in the adult walker, the Hammersmith score kind of stable roughly, but in the pediatrics, I guess, is where you see more of an improvement. So we all know that nusinersen, other than the inconvenience and the minor side effect, mostly related to the lumbar puncture. Having said that, some of you might have more problem with it, with a lot of pain when you have the treatment, and it's variable for the individual. It's relatively safe. And there is a suggestion that maybe over time, there is a small cumulative effect over a longer time from the Italian and the German registry. Now we might move quickly over to risdiplam, which you also know well of. This was the original double-blind trial called the Sunfish study, all the fishes, as you know, from age 2 to 25, involving 180 patients. And when risdiplam came on to compassionate use, and since then coming through PBAC, this is the last, I think, the double-blind randomized control trial that involves some adults. Now, the recent interim report was on the jewelfish. The jewelfish is a little bit different from the sunfish in that, in terms of it being used in people who have been treated previously with other treatments. So 66 of them have had nusinersen before, and 14 of them have had the gene therapy prior to that. And what they have found in the study that was published this year, but with preliminary results that was discussed last year, is that the SMN protein in the blood was actually increased by 2-folds, and there was a stabilization of the motor function as measured by the MFM32. Sorry? Sorry, I'm not sure.
Sorry, if we can just remind everyone to be on mute unless you're going to be asking questions.
Oh, sorry about that.
Question? I think we're okay. Cool.
Okay. Risdiplam, in terms of of the adverse effects, these are the adverse effects with the gastro symptoms in this particular study with pyrexia and headache. But skin kind of allergies or sun sensitivity of the skin is also another one that's been mentioned with the risdiplam. The real-world data for risdiplam in adults is not as robust as in nusinersen. There are different countries publishing often about 6 to 7 adults who have been on the treatment, and then just telling us their experience within their own country. So I picked the one that was published online last year from Northern Ireland. There were 6 to 7 people aged between 26 to 44 who had the treatment and had 3 monthly assessment over a 6 to 9 month period. And they reported subjectively that there was an improvement. I'll show you in the next slide the kind of improvement that they described, but there was no kind of clear change over that period of the objective measures in terms of kind of daytime sleepiness or the upper limb function or their spirometry. And this is what they've mentioned. Some describe kind of improvement in bowel habits, appetite, less fatigue, cognition, speech, cough strength, upper limb ability to move, hand strength, quality of life. So the patients are appreciating subjective improvement, but just not, we can't document it well enough. And in this group, the side effect that stands out is the skin sensitivity to sunlight. So this is just to mention that for patients who are on treatment, particularly with nusinersen at the moment and foreseeably with risdiplam into the future, we would need to monitor progress in the adults to show that they, whether they stabilize, whether they're benefiting from the treatment. And people who are on it have been hassled with 6-monthly assessment that involves questionnaires and coming in for an assessment without or online for 1 to 2 years. But it's just to say that it's actually on the PBS that we need to be, documenting that there is an improvement or stabilization, particularly after the 104 weeks, which is at the 2-year mark. And a lot of the adults are reaching that brink of the 2-year mark. And those assessments that you've put in the time for really helps us, to confirm with the government when we apply that we've crossed our heart to say that, yes, it's been working or helping to stabilize things. Now, with the pipeline, we just mentioned those. I won't go into that. And echoing Michelle earlier in the first session that we should not neglect standards of care. But now we go on to the discussion about consideration for nusinersen versus risdiplam. It is difficult because there's no head-to-head study of people being on, nothing on nusinersen and then on risdiplam to see which one is better. So we just have to, have a guided best guess in terms of the potential pros and cons of changing over to risdiplam, which I know a number of you are considering or starting, or those who might be on risdiplam or into the future, whether they decide to come back to nusinersen. So I'll open the floor now to discussion or pass on the time over to Michelle to discuss about the pediatric side. Thank you for your time.
Thanks, Christina. Michelle, do you have anything to add from your side on pediatrics or a discussion on there?
Yeah, sure. I think I do have one slide.
I will stop my slide, but this is some of the things that people will consider.
The host
Sorry
is
about
disabled
that.
Screen sharing, so it really doesn't matter. Don't even worry to fix that. I think in the pediatric space, because we do have 3 therapies, the dilemma of which one to choose and how to swap is something we discuss all the time. So I think I had a slide summarising the 8 things I think you need to think about that I like to talk to families about to share that decision and make the best decision for that person, which is different to other people with these 8 factors. The first one is clinical suitability, and I think that's different. And so it's about scoliosis and what is doable with scoliosis, because if you have rods, a lumbar puncture is very hard. It needs CT scans and sometimes anaesthetics. Now, with gene therapy, it's an entirely different clinical suitability. So and this is something you might have to think about in the years to come. That AAV that Michelle talked about, the virus, if you are immune to that virus, and lots of people will be, it won't work. And so putting yourself through it and all the side effects for something that doesn't work, don't do it, okay? And I think because you need to have a healthy liver and a healthy heart and healthy kidneys to be able to tolerate that as well. So we have had some people, like children, that we have said, no, you can't have it. It's not the best treatment for you. Even though people think it is, it's not always. That's clinical suitability. Number 2, how is it delivered? The frequency, and is it a tablet or an injection? And people have different preferences. Sometimes an injection every 4 months, you go away and don't think about it, is much better than having to remember to take something every day and keep it in the fridge. The risks are different. And so I think it's weighing those up. and also the requirements for monitoring, and sort of a day in hospital can be really inconvenient, and you may not want to come in there, and it's just very disempowering, and we always do our best not to be, but I get it, and it's horrible. And of course, ongoing care is not just about taking the drug, it's all the other stuff that has to go hand in hand with it. I think number 5 is your individual goals. And I think everyone's experience living with SMA is different. It's really important before you start to think about what is it for me that would make a difference. What am I doing now, and how can I sort of measure that over time to help me understand that? So if it's typing, how many words do I type in a minute, or how long can I type before I need a break? And just seeing where you are and then thinking about that over time would be a nice way to measure it, rather than the scales that don't make any sense or any meaning to people. And I think, of course, we always say, well, the outcome differs. It differs by where you are when you start and how long you've been living with SMA, what other therapy you have had, and what your function is. And then I think it's about the cost and access, and that varies, of course. So they're the sorts of things we talk about to help make the best decision for people. Ellie, you've got your hand up.
Provide that slide that we will attach that to the slides for today.
Yep, cool.
Thanks.
Absolutely. Thanks, Michelle. Ellie, yes, very, do you want to jump on, Ellie, with the question?
Yes, thank you. I've got a question, Dr. Christina. You mentioned with risdiplam that you get sun sensitivity. What do you mean by that? Do you mean that will burn easier, or it's too glary, or what do you mean by sun sensitivity?
I might actually also pass that question on to Michelle. I suspect she has more patients on risdiplam than myself.
I do. So, like, I guess my experience in treating babies through one of the clinical trials is that they can get dry skin, flaky skin, or eczema. But I honestly don't know. Like, I think a lot of kids get eczema anyway. So I'm not too sure if that's something that was going to happen to them. But the thing with risdiplam is that it has off-target effects, which means it actually upregulates other genes as well, okay? And one of those is a skin cell gene. And so it can make skin cells turn over faster and grow faster, which is why I think you can get dry skin. And in the mice, they did see that in the gut as well, but I don't think we've seen that in any people that have been treated. And I think that is why as well in the animals, it did show some changes in sperm production as well, because it doesn't just bind to the SMN2. And so we don't know what that means for people taking risdiplam, but I think it's something to think about if that is important. What we do think is that when you stop taking risdiplam, that is likely to be reversible.
Well, that's good, Michelle. It might clear up my oily skin, and also won't affect my sperm. So that's I can't wait to get on the stuff. That was the question, Christina, we were asking when we were trying to get you co-host. Like, when is this? What's the process happening now that the PBS has approved it? What are we waiting for now in terms of accessing the bottles, the starting treatment?
Is that a question now?
Yeah.
Yeah, so I think the drug has come through PBAC for adults, but just like last year when we were waiting for the nusinersen to come up, we're waiting for that process of the confirming the guidelines of what authority we can use it for in adults. And so it hasn't come onto the PBS yet. And usually the drug company knows and notify clinician just very shortly before it comes out on PBS. But I would presume the prescribing process will be similar to nusinersen, that we will still be required to assess patients regularly to see how they're faring, to justify the use of the drug for the person. So we can't prescribe the drug just yet until it actually has a listing on PBS with the particular item number and that we can ring to ask for the drug. And there usually is a bit more paperwork to prove the person's condition definitely fits this criteria initially. Then it's easier for the clinician to kind of ring a special unit to ask for permission with each dose or each 6 months that you require of the dose.
Mhm.